All right, welcome everyone. Thank you for joining us on this episode. It's the first time this year that you've seen our two heads together. If you're watching the video version of this one, you've been punished with just my voice for the first week and a bit of January. So thanks, Bo, for joining us in this podcast discussion today. Bo, we're going to talk about exercise prescription or corrective exercise, if you want to call it that, or rehabilitation exercise in the clinic space, and dive into different facets of that, why it works for some, why it doesn't work for others, and so on and so forth. So thanks for joining us.
Yeah, thank you. I'm happy to be back.
Good to be back. So, Bo, this is a question we get asked a lot by a lot of our students is like, when are you going to run a corrective exercise course? And we get this one a lot because I think it's a bit of a knowledge gap for a lot of health practitioners. We all know how to prescribe a stretch and maybe a few strengthening exercises, but actually putting it together into a program or something that is workable for an individual with an individual presentation is a bit of a barrier for a lot of practitioners.
Yeah, and this is such an important question to raise around exercise and how it should complement what we're doing. Because, no intervention that we do, whether it be manual therapy, education, exercise, it should be used in isolation. It's really about bringing this stuff together. And I guess starting off with even just the term corrective exercise, I think that's something that, it's a little bit outdated as well when we talk about, well, what are we trying to correct? Exercise should just be about promoting overall well-being, getting people back to doing their meaningful activities. So that can sort of lead us into thinking, well, how specific do we need to be with exercise? How much exercise should I prescribe or even recommend to a person? And what does that look like in a clinical setting? We see this all the time with patients saying, well, I've tried all the exercises and exercise doesn't work. And then you sort of drill into to what they've actually been prescribed. And they said, oh, I've been given, 30 reps with the TheraBand in this direction and then 50 reps in this direction. And you just sort of think, well, firstly, do you enjoy doing that? Secondly, is that stimulus enough to stimulate some change? And you're engaging with it. Do you think that this is going to be helpful? And in fact, is it helpful? Because if it's not, we've got to look at that and think, well, what's right for you and how can we modify this type of exercise to fit in with your life?
100%. And it really is a tailored system or a tailored program we're trying to put together for people. And I know I get the question a lot from clinicians saying, what sort of exercises do you give to somebody with an Achilles tendinopathy or a hamstring strain or low back pain? What's your best low back pain exercise? Well, you can't answer that question because there's so many variables in the presentation. How sensitive is the person? What are their limitations of movement? What's been the cause of it? Which structures are involved? Like there's all these different things, but then so there's the complex side of rehabilitation exercise or therapeutic exercise about tailoring it to the person. But there's also the idea of that you're talking about, which is trying to just promote movement because movement in itself is medicine. Trying to get people to move towards health, towards better function, towards their activities of daily living that they're trying to return to. And so we can certainly overcomplicate exercise prescription. And I've been guilty of that. I think you probably have too. So let's talk about some of the things that we can focus on to decomplicate or uncomplicate an exercise protocol for somebody.
Yeah, that's a great place to start because you mentioned before, what's the best exercise for something? Well, there's no such thing. In fact, the best exercise for low back pain is any exercise. There's no literature, there's no research to suggest that one exercise is better than another. And I think that's where people overcomplicate things by getting stuck in the specificity of something. With low back pain, well, you've got to strengthen your glutes, you've got to strengthen your core and all of that sort of stuff. Or could we just say, what do you really enjoy doing? What reduces your sedentary behavior? What do you want to get back to doing? And let's focus on that. Let's just get you walking if that's something that you enjoy. And in fact, I think it's important just to even ask the question, of all of you out there, just what is the percentage of the population who actually meets the exercise guidelines? And there's only 1 in 4 people in the world that meet the recommended exercise guidelines. And the recommended exercise guidelines is 150 minutes of moderate level activity and 2 resistance training exercise sessions per week. And so when you look at it that way, well, where do we start with exercise? Well, let's just start by getting you doing a minimum of 150 minutes of exercise per week. And then we could start to incorporate some resistance training exercise. And that has been shown to significantly decrease the burden of preventable diseases. So I think that's a really good place to start. And when we look at chronic pain and the influence of comorbidities and sedentary behavior and numerous different factors, mood-related disorders that can influence chronic pain, one of the best things that's free, if not very affordable, it's widely accessible, is just exercise. And if we got people moving more, then there's a pretty good chance that the levels of pain would start to decrease, their overall mood, the level of stress, the amount of sleep they're getting, and perhaps other behavioral factors and lifestyle factors can improve as well. And then all of a sudden their pain is getting better and they're getting back to more meaningful activities. So I think that's a good place to start.
Yeah, look, the evidence definitely points to cardiovascular, or I shouldn't say endurance, but cardiovascular type exercises being a powerful modifier of mood specifically. And so people getting out walking, running if they can, cycling, swimming, just being outdoors, taking the dog for a walk, these kind of things are powerful modifiers of mood. When we modify mood, we have the potential to influence pain dramatically, because so much of pain, especially chronic pain, is driven by psychological, psychosocial, emotional factors. It's not always physical. In fact, very rarely is chronic pain really driven purely by physical triggers or drivers. And so if we get a person, like you said before, what do you like doing? And they say, well, I walk the dog every day. Do you enjoy doing that? Well, I don't mind it. Yeah, it's good. Okay, well, guess what? You're walking the dog twice a day now. And you're like, great, no problems. How's that going to help my back pain? Wait and see. Like these things, it's not always obvious. And I think that's pretty empowering for the health practitioner, because we'll often think, okay, well, I've got a tiny little clinic room. There's not a lot of space for me to do exercise with the patient. There's no gym available to me. And I don't have space outside my clinic room. I can't do it in the waiting room. I can't do corrective exercise. I can't do therapeutic exercise. I can't prescribe exercise. There's no space. Well, you can tell a patient to go for a walk. You can encourage them to play with their grandchildren. You can encourage them to ride their bike instead of walking to work. Like you can encourage, that is exercise prescription. It's prescribed because we know that exercise works. It's not specific, but it's still exercise. And so I'm hoping that a lot of practitioners are hearing this and getting empowered to say, well, okay, I don't have to be giving them 30 reps a day of something, or give them the green TheraBand, or tell them to go to the gym and get a membership. Like all those things can be useful. But if we're really talking about a lot of specifically chronic pain presentations, just moving, just get them moving, and in a regular way, in ways that they enjoy, in settings that they enjoy, at times that they're more likely to do it, so that they become more regular and it becomes part of their routine. And as their mood modifies and as their health generally improves, and maybe their weight drops and a bunch of other things that can happen, their ability to not only tolerate pain improves, but their experience of pain can reduce as well. Like their tolerance increases and the pain itself can be reduced, because their body's in a better state to be able to deal with whatever they're dealing with.
Yeah, definitely. And you look at chronic pain and we think about what neurophysiological mechanisms may be associated with this. It's not necessarily about strengthening a specific muscle or, targeting it at a specific area. But when we've got these pro-inflammatory levels systemically, that can decrease increase sensitivity of the entire central nervous system. And so just getting some movement is one of the best things that people can do. So yeah, great place to start. And then, when you look at sort of getting them back to doing things that they enjoy doing, that's their decision. So we can ask those questions. What do you enjoy doing? Great. when would be an appropriate time for you? What fits in with your life? Because if I tell you, you've got to do this exercise twice a day, every day, and this will solve the problem. But what happens when when it doesn't, or when they don't have time to do it, and then it always comes back to blaming. Well, it's because you didn't do your exercises. But we've got to look at these overall lifestyle changes that go with it. But yeah, how can we fit these exercises in with their life, and also potentially improve social connectedness? If they're going and exercising with a friend, or if they're exercising in a group setting, that can be a really valuable component to it. You can make exercises fun. You can gamify things so that it's far more engaging. They actually want to do it without the thought of going, all right, I've got to do 3 sets of 10 repetitions. I've got to have 2 minutes rest, and then I've got to do that 3 times. And I'd rather watch TV. So we've got to sort of make it engaging, fun, and accessible for that person. So ask a lot of questions about, what you like doing, when can you do it, how many times a week do you think that you would be able to do this, and how long do you think that you would need to be engaged in these exercises? Because a huge mistake in prescribing exercises is that, well, do this for the next 2 weeks, and then when they say, oh, I'm not getting any better, well, the time frame is probably far too short. So we've got to think about looking at the long-term changes of this, because it may not be a short-term fix. This is a lifestyle change that's required, and this could be minimum 12 months. And hopefully, in 12 months, you're engaging more with this. It's becoming more of a habit. It's becoming more of a part of your lifestyle. So I think that's important, is setting those longer term goals and those more realistic longer term expectations.
Yeah, 100%. And let's go back a step now. So we've been talking a lot about chronic pain presentations, when really the goal is to just get them moving again. And we don't have to be as specific about it. Let's load this specific muscle, this much, repetitions and dosage and so on. If we come back to more acute presentations, some people might listen to this and think, well, I deal with a lot with sporting injuries, and they're coming in, 2 days in, they've sprained the or strained a hamstring or something. For the longest time, the research tells us we have to load in this way, in this many repetitions, and then progress it as they go towards their prehab or their rehabilitation program. If prehab, I guess, if they're having surgery. But we don't have to always be as specific, even with acute injuries, because if we look at the normal protocol for somebody to go through a rehabilitation program, say after an ankle sprain, one of the first things we want to do after we've managed the acute inflammation is really just get the range of motion back. And so maybe an exercise is have them walk. And you think, well, what sort of prescriptive exercise program is that? Well, walking will encourage normal and healthy range of motion of the ankle. So we don't always have to be as specific, even with acute injuries. Is there a need for training specific muscles or muscle groups as part of a rehabilitation program? Sometimes, in certain settings. And if you don't have the equipment, the settings for that, or the knowledge, well, then that's when we refer. We don't have to be good at everything. But our ability to prescribe movement-based exercise that can fit into people's lives can fit both chronic and acute presentations. Sometimes we have to co-manage with other practitioners, but that's why we have other practitioners as part of our referral network who have the equipment, the setting, the expertise, and then we can specialize in what we do. And that's how we give our patients the best outcomes. I think the mistake is that a lot of people go, I need to learn prescriptive exercise or the ability to prescribe exercise so that they can do that for everybody. Well, nobody can do everything for everybody, but you can help a lot of people with very little equipment and some basic understanding of physiology.
Yeah, and yeah, there are times when we do need to be that bit more specific, and it does depend on the population. But I mean, understanding key terms is important. So I'll discuss that. But also educating our patients about how to modify these key variables, because it really is about us as clinicians understanding load and understanding how we can modify load, progress, and regress. But also from a patient or an athlete point of view, them understanding those variables too, because that's such an important part of the relationship. And so so often, again, exercise can be overcomplicated. You see this all of the time in the strength and conditioning world. Oh, you try this program and you've got to do it this way, and this achieves hypertrophy versus this achieves more strength. And at the end of the day, we've got to go back to basics and understand, well, what are we actually trying to achieve here? And just to give you an example, in tendinopathy research, this has been up and down over the years around the types of contraction. You've got to do concentrics, you've got to do eccentrics, you've got to do isotonics, or eccentric only. And a recent systematic review and meta-analysis showed, well, that the type of contraction doesn't matter. It's about the load or the intensity. So the intensity has to be high enough to stimulate a response. And so when we think about a lot of these adaptive changes that we're trying to achieve early on, particularly in rehabilitation of musculoskeletal injuries, well, prescribing a load or intensity that is adequate is important. Far too often, the intensity is undershot. It is way below where it should be. So we do need to start with testing the person's current capacity. What can they actually do at this point? And so when we're looking at improving someone's strength capacity, we are looking at upwards of 75 to 85% of their 1 rep max. So it does need to be pretty heavy. So talking about intensity, and then when we look at our rep ranges, when we're talking strength-specific exercises. So when we're doing higher levels or higher intensity, often the rep range is much lower, because it's very unrealistic to be able to perform, let's say, 10 repetitions at 85% of your 1 rep max. So 1 rep max is the total amount of weight that you can move in 1 repetition. You couldn't do 2. So the maximum that you could achieve. So let's say that's 100 kilos in a squat. Well, 85% of your 1 rep max would be 85 kilos. And so at 85% of a 1 RM, you'd be looking to do between maybe 2 to 5 repetitions. Okay. And that's going to stimulate a strength response. And so when we look at the intensity, so that's how much weight, the rep range, how many reps we're performing, and then the sets. So, the set completing one lot of 2 to 5 repetitions, all right, and you might prescribe 2, 3, 4, 5 sets, depending on the person and depending on where they are in their rehab journey. So understanding those key variables are important, because, then as they progress, it might be that, well, you just modify those variables. You're just aiming to modify the total volume. So to find out your volume, it's the intensity times the number of reps times the number of sets. That gives you the total amount of work performed. Okay, so it might be that the intensity increases, which would transfer over to the total volume. All right. So if that goes up to a 90% of their 1 RM, all right, it might be that you modify the number of repetitions performed, so that increases or decreases. Or it might be that you increase the number of sets or decrease the number of sets, depending on the level of symptoms and how they're progressing. So those key variables are so important, as opposed to just mindlessly prescribing endless amounts of exercises. Because if we get those variables right, we're going to be far more specific and get the best adaptive response for that particular person. But then you can modify total volume. So you can see, well, in session 1, they lifted a total of 300 kilos. All right. And then session 2, that went up to 320 kilos. So if people are monitoring the total volume, and that's why it's always great if someone has a training diary, because if someone ends up with an overuse injury or tendinopathy, you'll see, well, there was a bit of a rapid spike here, and then we can go back to addressing and modifying those variables. So yeah, understanding those things are very important when prescribing exercise. Don't just mindlessly give out 3x10, 3x15. Well, what are you trying to achieve here? Are you trying to achieve a strength adaptation response, well, then perhaps that rep range needs to be much lower, and maybe the intensity needs to be much higher to stimulate that appropriate response.
Yeah, great. And that's a difference between focus on specific movements and specificity of load, isn't it? And it might be that okay, the exercise you're giving the person is a step up exercise, quite simple. You're training a bunch of different muscles. It's not specific muscle, but you can adapt or adjust all of those variables for that exercise if you can load the person appropriately. And so, yeah, I think that's a really good point, is focus on the specificity of the outcome of what are you trying to achieve for the person. And then the movements can vary, and they should vary. I think they should. And you want the patient to move in as many ways as possible, because return to function requires a wide range of different functions. It's not, I need to be able to dorsiflex my ankle or flex my knee under load. It's, I need to be able to walk up a set of stairs, sit on a toilet, jump out of bed, chase my child, whatever I've got to do. The other thing I think is worth pointing out too is when a patient has a setback, their progress drops or goes backwards. It's not always the fault of the exercise that's been given. There's so many other things to consider. So when the patient walks in and says, "Oh, actually, my pain's back," or "I couldn't lift as heavy this week," or "I couldn't keep up with the number of reps you gave me," whatever it is, we go, "Okay, well, what are the other things going on? How's your sleep going? Are you sleeping well? Are you stressed at work? What's it like at home? Are there any new things that have happened in this last week? Let's forget about exercise and your physical discomfort at the moment. Is there anything on the periphery of your life that has changed?" Because all of those things can change your physical capacity, and also your ability to focus, and your ability to be engaged and motivated in the exercise, if that's where you were before. And so ask them these questions, really dive into the person, not just the problem. And then if nothing else has changed, we can go, great, okay, so what we've probably seen here is a bit of a plateau in your progression, or maybe a bit of a dip, which tells us that maybe we've changed too many things. Maybe we've varied too many variables. And so did we increase the intensity too far? Did we increase the number of repetitions or the dosage too? Let's wind something back so that we can go forward, one step back, two steps forward. And that's where we can get specific too, is like really dialing in on what other variables, what can we control, what can't we control? Okay, it's gotten stressful at work. It's gotten stressful at home. Okay, well, let's control the amount of exercise I'm asking you to do. Let's go less specific and get you just moving for a week. Take the load off you mentally. You're not focusing on the exercises in the gym or wherever you're doing them appropriately. Cool. Stop that. What do you like doing? You like swimming? Cool. This week, go for some swims. Just move. All right. We're going to let your body recover for a week, and then we'll go again as you start to manage these other components of your life. And this is where the skill in a clinician comes in, is being able to pick out all of those things and then provide the appropriate direction for the patient, because it's a person, not a case study.
Yeah, that's a good point as well. Because we do need to look at all of this together. When someone comes in, and it always will depend on the population as well, but someone comes in with a load-based presentation, and then you go, great, I'm going to prescribe some exercises. Well, hang on a minute. Maybe they actually need a deload. We need to look at what they're doing, and then we say, all right, well, let's cut this in half by 50%. I don't want you to completely stop, but I want you to have a light week. All right. So modifying it that way is important. It's not always about giving more. It can be about taking some away. So we've got to, I think one of the most important questions is give me some detail around what your current exercise and movement looks like. And, if that's not a lot of exercise at the moment, well, what's involved in your daily activities? What's involved in your occupational duties that we may need to look at, that may be also contributing to the amount of load placed on these areas? And as you touched on nicely, Shaun, is pain is an experience. It's a conscious experience that can be influenced by numerous other factors. And it may be that pain experience is the manifestation of heightened levels of stress, significant changes in their life, their relationship, all of these other factors. So, it's not just about giving an exercise which will have I guess, an equivalent relationship to equaling a fix. It's often far more complex than that.
It's a shame, isn't it? And we keep saying in our conversations over the last few years when we're recording these episodes is that it's more complicated than that. It's more complicated than that. It depends. Like, and it's the truth. Like I said before, we're dealing with human beings, and they are complicated beings. There's a lot going on up here in the brain, and there's a lot going on in the body. And so there's no way, like you said earlier, there's no way that there's a perfect exercise for low back pain or a perfect exercise for hamstring strains. There's going to be a perfect exercise for a person, and it's going to be perfect because they do it, for one, they are consistent with it over time, and they see results, and then they modify it over time according to their progress as they're going. And that can be an increase or a decrease or a plateau, like any of those things. But it comes back to that person, which is why it's so complicated. So I think the complicated nature of exercise prescription doesn't come in the exercises themselves. It comes in the person that's presenting in front of you, and then how creative you can be at tailoring it to them and their life and the goals that they're trying to achieve.
Yeah, yeah, and I use this analogy I got from Dr. Mervyn Travers. I think it's such a useful one. Is a tube of toothpaste. You know, when you're prescribing exercise at the start, just getting for general level, you know, even moderate level exercise, you prescribe anything or get them to engage in anything. It's like pressing on a full tube of toothpaste. You're gonna get something out. It's when it's the high level, high performance level athletes that it's like the end of a tube of toothpaste where you've got to really squeeze it in the right way to get even the smallest bit of toothpaste out. So at that end, that's when you need to be really specific. But I think in general, musculoskeletal chronic pain presentations, just getting them moving and prescribing something that they can engage with, that they can do regularly and that they enjoy is a great place to start.
Oh, that's a perfect analogy to end with. I'm going to leave it there. Thank you very much for that. Guys listening and watching, I hope that you've taken a couple of pieces away from that and just have the confidence to just to point people towards movement, I think is what we're trying to say today. Get them moving and see what that does. And you can experiment on your own body. Like it was the last time that you took a break from exercise. How did you feel? When you went back to it, how did you feel? And that can be, it goes for anything. I don't think anybody's done exercise and walked over a period of time and said, "Oh, wish I never took that up." Like, of course, we benefit, and so we have to remember these basic facts when we apply them in clinical practice as well. So, thanks, guys. Thanks for listening. Thanks, Bo. Talk to you soon.
Cheers.